Week on Post Call, our interview is with Janae Sharp. She is the founder of the Sharp Index, which is a resource for awareness and prevention for physician suicide. Also, Emi Okamoto, MD, is back, of course, all the way on the other side of the world. She's just starting her day as we record this. She's got a big meeting coming up, but before she does that, we're going to talk about the med student perspective on physician suicide, and we're going to talk about how a Silicon Valley company, Groupon, is possibly saving people money on their healthcare. Emi, that's crazy. I just want to know when I can get my sandwich delivered, but some people are using Groupon to get cheaper healthcare. It's a different level.
Yeah, Groupon. Remember when the days of Living Social way back when?
Oh my God, Living Social. I remember those commercials on TV.
And right now I'm eating a dragon fruit. Nick, do you know what a dragon fruit is?
You know what? Honestly, I do. And I'm going to tell you a story that you're not going to believe the randomness of this. So before I went to undergrad, I was in community college in Wyoming, right? And there's a professor there who had been teaching at this community college in Wyoming forever. He was one of the world's foremost sources on all things in the Indian Ocean, west, all the way through all of the Pacific Islands. So he had breadfruit and dragon fruit for us to eat in Rock Springs, Wyoming.
But that's not what, it's so good.
It's
the
unreal.
Pink ones.
Yes.
Yeah.
100%.
Magenta.
I could definitely use some of that here. So we're going to try something new this week. We're not going to do the quiz, mostly because we feel like we're sort of relying on the quiz to create content. And if you are mad about that and you like playing along and you want it to be backed by popular demand, feel free to email us and yell at me. Okay, so let's get right in. Yeah, that's exactly. I think I'm underestimating. I think some people might be upset. I think I'll be surprised. So we have two things that we want to talk about this week. We're going to do a little bit of a journal club, two Medscape articles that caught our attention. And I want to start with the Groupon thing because everybody agrees at every level that the healthcare system is quote unquote broken and that these people need insurance and this pharma thing and that doctor thing and all this crazy stuff. But this all started from a tweet. Nicole Herbst, which I believe she's a clinician. I'll look into that in a minute. She says, this is the quote. I saw 3 patients in clinic for abnormal chest CTs brought on by Groupon. Evolution of my thought process. What the F is going on? 2, actually, that's priced pretty reasonably. And 3, as she Googles it, she said, geez, if I ever need testing, I'm going to go with Groupon. It's probably cheaper than insurance. Emi, what the hell?
Yeah, this is a great question. Yeah, I clicked on the Groupon link for the one they actually just link in the article. It's a EBCT scan for the heart for a remarkable $25 today only.
$25.
Other days it's $28. Yeah. And this is healthcare. It's a consumer industry in many regards. And now we see even diagnostics being brought directly to consumers, which throughout the world is what a lot of people did. I had a lot of patients in Philadelphia who'd come to me from other countries saying, hey, I just got a big binder report and I'm 40. I have my PSA. I have my all my cancer testing, and you're like, oh gosh.
Wow. Yeah, what's really interesting to me is that there are two things. The first is that because it is consumer driven in a lot of ways, we know that it's consumer driven because some of the big hospital systems are always advertising, which means they want your business or your insurance's business or the relationship, and everybody knows about referral bases, but that means that there are competitors that can do the same thing, hopefully with the same efficacy and safety for cheaper. But also we're living in a world where people are looking at something and think, oh man, I bet you there's a cheaper way to do this. And they go to the thing that saves them money on axe throwing and yoga. Like their thought was, I bet there's a better way to do this, right? Like or
they're just clicking around. They're like, maybe we'll go axe throwing this Friday, and they're like, oh, maybe we'll get a CT scan of our heart.
I like to think about that too. You ever been home in your relationship, and you're like, you know what? I bet this exists. I bet there's an app for this. And then you Google like, holy shit, there's 5.
Yeah.
And
as you mentioned with price, it does drive the price down. So I'm not a fan of, patients choosing their healthcare without wise
Sure.
consultation, which I think a lot of people would agree with. But at the same time, look how the sticker price on this, and you can kind of framing or at least curving this kind of price craziness that's going on with the healthcare in the U.S. today, where the sticker price on the U.S. healthcare system doesn't even represent anything because it's always bargained down by insurances, but paid in full by, uninsured patients.
Right. Which is what, yeah, exactly. So like, and if you didn't have any access to any of this information, it would be, there's not even a real way to access it, which is the craziest part to me. So I think this is most innovative, obviously from Groupon. I think it's innovative from the people who thought, let's just try it. I can see it in a meeting right now where they're the old guard and there's a young person who knows about the internet and says, just shut up, everybody, just trust me this one time. We're going to put it on Groupon. And then I also think about the patients thinking, this is really clever that you looked for it there, or that it was targeted to you on an Instagram ad. I mean, everything about this story I love a lot.
Yeah. Yeah, it's just we can't necessarily avoid it, so we might as well figure out how to work it into a better system.
Right, and especially if you can make it safe and efficacious, right?
Mm-hmm.
So this was this is from she was an this is what her Twitter bio reads. This is where I'm giving you the bio of the person who tweeted it. Nicole Herbst is the former IM resident in chief of BMCI, which I don't know what that is. Let's find out. Oh, BU, Boston Medical Center. Mm-hmm. You can never tell what things are from their Twitter handle. And she's brand new pulmonary CC fellow at Emory. Oh, she's going down to the dirty South. How about that? Or is that in Boston? Emory's in Atlanta, right?
Yeah, it's in Emory.
Atlanta,
hot
right?
Atlanta.
Okay, hot Atlanta. Peace up, A-Town down. That's right. Yeah, I went to high school. So
yeah, and what's cool is that you can just see kind of how you're seeing something in clinic and how you can broadcast this and really spark a news story and share with people your experience. Just one tweet can really get you out there.
Right. Well, and she gave her analysis, which was really interesting because in the same instance, she was both a user of Groupon and a clinician. But I mean, I love that her first reaction was like concern for her patient, like someone's going to go out there and get off of your phone. But then it turned out to be okay.
Yeah. Well, yeah. Well,
yeah.
I've seen a lot of incidental findings blown out of control from these types of things. So
social media
everyone
is what
very
it is.
Wary.
Yeah. No, for sure. The other thing I wanted to mention before we get to our suicide stuff is that the Juul vaping epidemic is out of control. It's been in popular media in the last couple of weeks. MD Edge has been covering it very aggressively, I would say, for the past 6 months or so. And now the Trump administration announced today that they are going to move to ban all non-tobacco flavored e-cigarettes, which would mean that it would be indicated or suggested only for those people who are addicted to smoking cigarettes as a way to quit. And they are also, Juul, the company, is also being scrutinized aggressively for their marketing. So all the candy bubblegum flavored Juul via the Trump administration it looks like they're going to try to ban it from existing in the United States. And then they're also in trouble for marketing to people who are not of age to possess the product, which I think that's a great move by the Trump administration. This is getting out of control.
Yeah, we've all waited for it. You don't need, e-cigarettes the same flavor as your 7-Eleven slushie.
Exactly.
Ooh, that's for kids.
I remember being in high school when snus came out, and it was a toned down version of tobacco patches, but it tasted like gum. And I had dipped, and I was 18, and I had been dipping, and I lived in Wyoming and played baseball and all that, and it was gross, and I never should have done it, and I wish I never would have. But I remember when this came out, and I thought, I don't even have to spit. This is cheating. This is not for my dad. This is for me. So that I can do it in school and at work, and that it can get people who are grossed out by tobacco on. And I thought, this is really dirty. This makes me feel icky. And Juul is the same way. And we don't know any of the long-term effects of the vaping. This is all the emergent stuff. We just wait for 20 years. Mm-hmm. So it's a good move by the Trump administration. Credit where credit is due. Okay, so I want to talk about something that we've been discussing over the last 10 days at MD Edge, and we're going to on and off continue to discuss until October, which is Suicide Prevention Day. Was, as we record this a couple days ago, it's Suicide Prevention Week. We're wrapping it up, and Suicide Prevention Month. Physician Suicide Awareness Day. I keep Googling it. I can't find if there's a specific day. There was the first ever or second ever one was last year. But as everyone knows, rates of suicide in the country are going up. Rates of suicide among physicians are going up. So we're going to talk about someone who's our interview guest this week is someone who's an advocate of that. But before we get to that, I want to talk about a med student's response to physician suicide. As we investigate burnout and its relationship to suicide and other psychiatric conditions, go all the way back to the genesis, which appears to be sometime possibly in med school. So did you read this article, and what did you think?
Yeah, it's so different to hear it from a medical student. We're so used to lamenting as physicians and professionals and residents about the really tough work that we do. And he's or she is here. Who wrote
Emily
this?
Cahood,
Now
I think.
I have to look it up.
Yeah.
Yes, she is here, really pointing out. This is how it looks from the trainee perspective, seeing other people talk about, oh, I work such long hours. This is hell. This is really hard. And how that affects, medical students and their perception of the career that they're going to choose, which is something we need to be really cognizant of, how we can shape the future generation, which isn't to say we shouldn't be having these discussions and having them, involving medical students. We shouldn't be shielding them. But it's also a perspective that I don't think about as much.
Yeah, it seems to me that in the grand scheme of things, there's such a fine line between what is the system beating you down at an unhealthy rate and what is the system is just really hard, and everybody, patients and physicians and nurses and systems, benefit from it being really hard. I like that trauma surgeons have immense experience in being awake for 28 hours. That makes me feel better. But when you read this and you see like the little things and like the weird sort of thing that I've noticed that I took away from this was the idea of impending doom, where you hear a PGY2 tell an intern, just wait. Or you hear a fourth year tell a third year, just wait. That means that at some point you thought that you were going to cure cancer and that you have all these great hopes and ambitions, and you're young and you can conquer the world and things are going really well, and then it starts to seep in and then it never gets better. Year after year in your training, you hear these people, it's going to get worse. Wow, it is insanely challenging. And that was something that I never really had read, never really put into words. But I got impending doom out of this.
Yeah, and it's the whole, concept of like self-fulfilling prophecy. If you continue hearing things over and over and internalizing this is the way it is, then it's hard to break out of that.
Yeah, no question about that. And it starts in, as early as it can for anybody who's going through something like that. And we all agree that suicide rates, we reported it earlier on one of our daily news podcasts, which is for clinical information. The suicide rates are going up. They've been going up for a long time. A lot of different factors. It's not just physicians; it's most people. But it's obviously essentially an occupational hazard for physicians, and apparently it starts as early as med school. And I know data on that are pretty good, but they're also continuing to come around. So it's pretty intense. It's nice to hear this narrative piece, though. It's available from Medscape. We are, of course, owned by WebMD and Medscape, and you can get the link to that in the podcast notes. So we're going to continue this dark conversation. It's going to get a little darker, but it's important. It's something we need to talk about. Our guest this week is Janae Sharp. Her husband died by suicide while he was a physician. I believe he was in the end of his training. You can read her profile again in a link in the podcast description. And she's since kind of dedicated her life and her professional life to raising awareness and providing resources. Her website, sharpindex.org, has surveys that not high-level clinical care, but it can kind of tell you maybe you should check this out. She also has grants and scholarships available for anyone who wants to work in this area, whether you are a healthcare professional or not. So I'm pretty excited for this interview, Emi. This is something that, goes all the way back to day one when somebody recommended you read House of God,
Yeah. And I appreciate, someone, not just the physicians leading this moment, but it touches and affects all the people in our lives, particularly, those around us and our significant others. So I'm really interested to hear that perspective. And I do encourage everyone to not only involve your significant other, but also just be cognizant that they're there and they're helping, and how you can use them, and there is actually, interestingly enough, a scholarship for non-physicians. So if your significant other is really into supporting you and supporting the program, that might be something for them.
Absolutely. And there are other scholarships available, obviously, for people who are in the profession as well. And if you are interested in doing some sort of work, or you know how you could use the money, or if you have a mentee or a colleague that is interested, all of that information is available. We're plugging her website this week because we think it's such a great thing. It's all available in the podcast notes. And if you feel so moved that to donate to this issue, or you feel as if you're in a place where you need to take the questionnaire that's available on the website, that's available in the show notes as well. Yeah, a bit of a heavy topic this week, Emi, but this is sort of what the show is designed to be about, so it's not something that I felt comfortable ignoring,
Yeah, it's good to talk about. Thanks for bringing it to the light.
And I want to give a shout out to our design person. Her name is Luis, and she designed a lovely adaptation for our logo with the suicide prevention. I'm not sure have you checked out the logo? We got a little suicide. Yeah.
We have a little ribbon. Yeah.
Yeah, I appreciate it. Here's the thing, folks. I don't know how much you know about it. That is actually really hard. So I was super impressed. She got that to us in 72 hours. I was really impressed by that.
Great.
So, Emi, how's your sweat rag doing in Cambodia?
How's my what doing?
Your sweat rag.
My sweat rag is sweaty.
Last time we talked, you said I have got my
salty.
Sweat rag. Yeah, you're like an athlete on spring
Sweaty
training.
and salty. I have multiple though, so it's all good. Just switching them out. Got the pink one today.
That's what I like to hear. Well, don't go anywhere. We've got our important conversation, uplifting in a very good way, with Janae Sharp coming right around the corner. Emi, thanks for hanging out. We'll see you again next week.
Very good. Thank you, Nick. Bye now.
Welcome back to the Post Call Podcast. I am talking with Janae Sharp, and the topic this week is a heavy one, and one that we focus on quite a bit here at Post Call and at MD Edge, and that is physician suicide, Suicide Awareness Week. Of course, September Physician Suicide Awareness Day. I believe the second annual one ever is coming up, and so Janae, this is an issue very important to you, and I want to thank you for being brave enough to come on. You make a life out of doing this kind of work, and it's a very big passion for you, and I really appreciate you coming on the show.
Well, thank you for, making the time to cover this topic. Like, it's really important. And I just think about how much progress has been made. A couple of years ago, there was nothing like this out there. So I just think it's important that the conversations have changed.
Yeah, I think so too. And that's what we try to do, specifically with this show, is just provide a platform for these kind of things. So, like I said, it's really great that you are joining us. So I wanted to start off by saying that you do this thing called the Sharp Index, and will you tell me what that is and how it works?
Yeah, so the Sharp Index is actually the name of our nonprofit. We started a nonprofit last year to reduce physician suicide and burnout. And we do a few things there. The index itself was developed with in cooperation with some licensed clinical social workers and physicians, and measures physicians' state as in like mental health questionnaire and burnout questionnaires. And we want to know more about that relationship. Like, is it a spectrum? Like a lot of people talk about, burnout to depression or not. But the nonprofit Sharp Index is just the name of the nonprofit. So we do other things as well. Like, we want to increase awareness. We also have a scholarship for physicians one for a physician and one for a non-physician, so someone else who cares about burnout. And we're interested in anything that meets with the goals of our mission. We also look at organizational change, because most of the issues come from being part of a system that's broken. And so we want everybody to have tools. You want mindfulness, but also we need to fix something that's broken. Otherwise, it's never going to get better, no matter how much, no matter what you throw at it.
Right.
So,
And yeah, absolutely. I think that's a really interesting point that you make, that because it's obviously individualized strategies are extremely effective, not only in this realm, but your entire life. But the system seems to be the issue. Yeah.
Yeah, I think it's interesting too, because I'm a real proponent of things like mindfulness or yoga to help with stress, and it really helped me with my stress when John died and raising my kids. But at the same time, like, we need to look at the root causes for these things, and that's a big problem.
So let's jump into what you just mentioned there, with how it affected your life. Will you just talk about what motivated you to get into this line of work, and as much background as you feel free to go into? And I want to say that your story and a bunch of resources will be available in the podcast notes as well, but just could you go into what your motivation is?
So my former husband died by suicide 4 years ago, and we have 3 children, and he didn't finish his residency training to become a physician. And a few things kind of really struck me. One, it was like a lot harder than I anticipated to have a suicide death. Like, I wasn't really prepared for how difficult death was, and a traumatic death, but also I was frustrated with the resources available for my kids and the way that type of death was just hushed up, and some of the shame surrounding that. Also, when I would talk to people in academic medicine, it was all about measures and, oh, don't worry, there's tons of suicide prevention stuff available. This is an established science. And I was pretty frustrated, just thinking, well, if it's an established science, like, what does that even mean? And are you just saying, like, this is just like an F up,
Right.
So decided to start things dedicated to working on that, improving the conversations, but also to kind of destigmatize that type of death. I was so frustrated for my kids, just that their dad didn't have the same type of honor. Like, people wouldn't say the same things as they would with any other type of death or disease. And it was really hard to decide to start that.
Sure.
Because I know that medicine is self-critical, and everyone there is, not everyone, but many of them have this perfectionistic culture. And when John died, it felt like no one really wanted to talk about it. So when you're the one bringing up the topic that no one wants to talk about, that opens you up to a lot of criticism.
Yeah, it makes you vulnerable, I would imagine, right? Not only do people kind of want to avoid you for not knowing what to say, but also here you're kind of attacking this system that they're all a part of.
Yeah, and it's a system that they've succeeded at, but also it's a system that they've gone to school for 20 billion years for and invested millions of dollars into.
Right.
So, and that's your livelihood. And with physicians, I think a lot of times it's also mission driven that they start being physicians.
Yes, sure. Absolutely.
Anyway, but I really wanted to do something. I didn't have all the answers, but decided to start anyway. I think largely too, because when people came and talked to me, it seemed like, oh, this one case must be some kind of outlier because the science exists. And I think we want things to fit into this neat little package, even with physician suicide. And that helps us to like feel safe and to separate us from the physicians who lose their lives and who are broken, you know?
Right.
And it's been really rewarding, I think. And it's been really rewarding to see how the conversations have happened. So I always say, like, I'm a physician suicide loss survivor. I'm not perfect. I'm a mom of 3. I'm someone who's trying to make the best out of a situation. You know, a lot of times I learn new things about science. I learn new things about programs that exist. And I like that approach. And it's really impressive to see how many people, even if they aren't working on this, all the physicians that I know care about this and have been impacted by it.
Right, and it seems like I forget the statistic. It's an average of a medical class, a graduating class a year. Is that correct?
Yes, and the average is about 1 physician dying by suicide every day in the U.S.,
which is, you know, astronomical. I think the thing that really put it into perspective for me, and you can make stats do whatever you want, but the thing that really kind of made me stop and think was that earlier this year we reported for, I think, 2016, 2017, that it was the leading cause of death for male residents and the second leading cause of death for female residents, which means that, you know, when you buy a pack of cigarettes, you have this warning from the Surgeon General that says, you know, this might kill you. Well, that means that, like, now if you are going to match into a residency program, it stands to reason by that logic, you know, like, this might kill you, which is really sobering for me.
Yeah, your risk for suicide death goes up starting in medical school, actually, and just stays really depressingly high.
Yeah, and then it never goes away. Which you make light of it, but because that's a coping mechanism. But it's something that I don't like to say that I'm glad that it's being talked about at a really high rate compared to what it used to be. I know that the House of God turned 40 this year, and the big moment in that book was a resident suicide, and it's taken 40 years to get to the point where now there are robust tools and there's robust conversation. And I think that you're a big part of that. So how have you seen the landscape change since you went through what you went through and started your nonprofit?
I've seen a lot of the conversations change, and a lot of the people talking about what happens have changed. When John died, I felt like people thought there was, you know, it was an outlier thing. And there were a few people who talked about it, but everyone wanted to discredit them. And now everyone can talk about it without being discredited. And they also admit more freely that it's a systems problem. And that's something that's really important, because I don't know how before they're like, no, it's no big deal. We don't need more than 4 hours of sleep a day. Like, these are people who studied medicine. So they needed to be able to admit that, oh, yes, we are also human and need sleep in order to maintain our sanity. Also, conversations like stuff where they talk about moral injury or moral damage and likening it to something with PTSD is very different. When I first started looking into it, there was some research that said residents had symptoms of PTSD and were responsive to treatment for PTSD. But that's very different conversation than saying, look, this is a moral injury. We came here to be able to do good and to be able to heal people, and the system is not enabling us to give great care. And I feel like we've reached a heightened state of dissatisfaction in the conversation where it's okay for people to talk about it. We haven't yet reached a pinnacle of solutions. A lot of the programs that people have, maybe they have a great publication, but they don't refund the program to provide support. So the solutions haven't yet infiltrated the practice of medicine and the practice of training physicians. But just the conversation has progressed so far from even 4 years ago, that it's amazing.
Which is, I think that's something that's really exciting. And it takes, people like you, and it takes this event happening, and it takes hard data to where you can say, like, this is not an outlier. No one has ever been an outlier. This has been a trend that's been under your nose or kind of not talked about or taboo or swept under the rug. And now when you talk about solutions, I mean, off the top of my head, doing this work for this podcast, the problems I hear with regard to burnout. Now, I feel a little bit less comfortable talking about suicide just because that's a psychiatric situation, and we have a show for psychiatry. But for burnout, I know off the top of my head, which may be correlated, the EHR is something that people talk about, the training. I found a really weird thing that I never really thought about, but makes sense, where I hear from students that around their 3.5 years of medical school, they realized that maybe this wasn't for me. But at that point, they were $250,000 in debt, and the only way to get out of debt was to be a doctor, and they were trapped. And like that, what a really kind of weird prison to be in, and things like that you never really think about. And if you are, the squeaky wheel in, pop culture and reality in a day job, you can have more options. But when you are part of a system, like in a football team or the military or in medicine, the squeaky wheel does not always get the grease. The squeaky wheel is often ignored.
Yeah, or fired. Yeah, and that's something, actually, that happened a little bit to John too. Like, I remember his first year and his third year, he really just felt in over his head, but he didn't feel like there were any other options. And I really like what you're saying with talking to people. You're so far and you've invested so much, but you realize, oh my gosh, this is not what I imagined.
Right. And the financial thing is they're held hostage because the only way to make enough money so that your life isn't ruined is by being a doctor.
Right.
Which is crazy.
Yeah. You might find a program with student loan forgiveness. And that's why I'm really interested in companies too that do things like telemedicine options, or allowing physicians to have some sort of alternate schedule lifestyle. That's a huge opportunity to improve the system. But it's entrenched. And the other thing that I notice is a lot of people complain about it, but healthcare also does a lot of good things.
Sure.
Yeah.
Well, yeah.
So
I mean, I like it.
Yeah. So organizational change is something that is incredibly difficult, especially when there are financial incentives. And this is a fifth of our economy that we're talking about.
Well, and it affects all people, right? Because we're all patients.
Yeah. Yeah. These are people who are responsible for healing us.
So you talked about your, go ahead.
Oh, go ahead. You had a question.
Oh, sure. Yeah. I was talking about, you talked about your late husband and how he wanted to seek help. And I know that there are stigmas and different ways where psychiatric records of physicians can be pulled in lawsuits for malpractice. And there's a lot of stigma around physicians and healthcare professionals having mental health issues. And I wanted to know what your nonprofit is doing and what solutions are being discussed at cocktail parties and at meetings in the hallways right now.
So one thing with the nonprofit is you can't really do too much lobbying. So as a person, I support them not asking mental health questions on physician questionnaires.
Sure.
Some states have that, some states don't. It was also really interesting. I remember before John died, he didn't die on his first attempt. So he was trying to get help. And someone said, oh, well, they have one attempt, then they can still practice medicine. But if he has two, then he's out. I couldn't believe they said that.
That's one of the coldest things I've ever heard.
Yeah,
wow.
Like, oh, well, that's just stress, but, that would indicate a real issue. And I'm like, oh, okay.
There is a real issue, as demonstrated by the first attempt.
Seeking help is something, first of all, when are they going to have time to seek help? Even if you say you have a problem, like during the 4 hours that you're not working?
In your own hospital where everybody can see, right?
Yeah. And in a lot of areas, you can't get psychiatric help outside of your healthcare system. So that's a giant issue, creating access to help. And I love the work of people who are saying we have to change the laws to make sure that that physicians aren't discriminated against for their mental health status. That's not within the nonprofit work, but generally, like, that's so important to be able to change that stuff. And some of the things I care about, since I work with a lot of companies that not work with them, but like generally know about them and care and think they do great work. I like companies that look at actual physician scheduling. Like, what if every resident actually tracked their hours for real? And what if their work hours counted and not just the time you're on the floor and then you have to do all your notes at home? Right. So there are so many technicalities that people are using to get around the laws rather than making it healthy for physicians. And that's an issue. I think it'd be so easy to have something where scheduling is smarter. And I like the company Lightning Bolt. I'm on their advisory board too. Mm-hmm. So separately, they do that type of smart scheduling where you can schedule people off call. And I'd love to see a requirement that you're actually tracking resident hours.
Right. And for them as well as for their patients and everybody, right?
Yeah. Like, I don't know a single person who hasn't lied on their residency hours.
Yeah, not one. Me either.
Like, none of them.
0%.
0%.
Yeah,
I know of.
I mean,
like, if there are any, please reach out.
Yeah, I would love to talk to you if you're straight in your hours for sure.
Yeah, like,
which I think we're laughing about it.
That hospital system says never fudge your hours, and writing your notes or discharging patients counts in your hours. Like, please. Like, I'd love to find that hospital.
Right.
I
know. Like, everybody, you can log your hours on computer or by hand in some places. I worked at the NFL at NFL Films, and they had biometric, and then they cross-referenced it with camera data so that you couldn't clock in and then leave. So, like, there was, when you said you were there, they would instantly, because they have all this money, be like, yep, you were there for sure. We know that you were at least in the building. And I think, like, that doesn't seem like it would be that difficult to implement. It seems like they just Googled biometric software and they got it. But now there's a system set up to do it. Yes.
If they wanted.
Right.
That's the thing. Like, how hard is it really to have Chronos or to have a scheduling thing where you're actually logging in and logging out? And maybe some of it's like physicians aren't really that type of worker. You're not an hourly worker.
Right.
But I mean, across industries you see in America, like, when people are salaried, you end up working many more hours.
Because it becomes expectation once you,
Right. Yeah, you're salaried, pretty much you're going to work 80 hours a week. The only problem for us not for us, but like, the problem here is that you're having people work in unsafe situations for them and unsafe situations for everyone. So maybe a more proactively healthy approach, it sounds like the NFL has one, is something they should do.
Ironically,
and
right?
If the NFL is healthier than you, what?
Right.
That's going on?
Right. We had catered food and stuff, and I've heard residents like, we don't have enough food cart. Like, I had a really high level breakfast every day. I don't know what you're doing, but it is the dichotomy of money too. We get into the business part of it. The NFL is printing cash, so they can do whatever they want.
Right.
And I think that's another conversation.
Performance matters. Like, they are a performance-based group.
Which, absolutely. And you turn your self-worth into these data outputs, and then, if you aren't your quota or your output, then I imagine then that can really mess with your psyche, and I would assume that that's where we're kind of looking at the link between burnout and suicide.
Yeah.
But so I want to talk more about the work you're doing with your nonprofit and how it can impact physicians today. I see that there's a questionnaire, and it asks me on your website, quote, where it says, we want to stop physician suicide. And there's take the questionnaire, and you have a scholarship. So why don't you tell me what the questionnaire is and how it works?
So the questionnaire I do want to say, like, questionnaires don't solve burnout. People love quizzes, and I love quizzes myself. Like, I'll take quizzes all day. But
Yeah, Ravenclaw all day.
yeah,
For
what
sure.
was that?
Ravenclaw. Yep.
Yeah, right. My daughter is Hufflepuff. And she loves it.
That's adorable.
I'm like, daughter, you don't even know that that's not okay.
Yeah, you don't want that one.
I'm like, oh, yeah.
Any other one really would be fine.
Like, sure, why are you going to take the quiz again and cheat? But yeah, so it is basically a standard measure of burnout, the Copenhagen Burnout Index, and a PQH-9 put together. So you'd be able to get a good picture of, am I burned out, and am I having, depression or stress? And a lot of that is so we can figure out more of that relationship. And in our research, they're not necessarily related.
Right.
There are a lot of people who are burned out and depressed. There are people who have healthy coping mechanisms who are burned out and not depressed. There are people who are very depressed. And the challenge is to get treatment for them.
Sure.
And to connect them with real programs. The scholarship is something, it's not a giant scholarship. Ideally, big health IT companies would be having a system of scholarships or of student loan forgiveness actively as part of their, maybe as part of their marketing. It's great PR.
I agree.
Say, oh, look, I took care of this medical classes debt. Done. We're starting, since it's a tiny nonprofit, like, we're just having a scholarship. I think it's up to a couple $1,000s for each one, for physicians and for non-physicians and people who care about burnout and want to do work in that. But I've kind of left it a little bit ambiguous, like you could do something with the money, like for student loan forgiveness, for anything. And we wanted to have non-physicians, just in case it's someone who is in healthcare IT or in media who cares about this topic and intends to do something there, but they're not physicians, or even survivors and lost survivors. And yeah, all the donations until the scholarship is awarded, all the donations to Sharp Index will increase the amount that we give to the winners or the number of awardees that we have.
Sure. So, so the link to the scholarship, what's that?
Even small, like, I think everyone should do something positive. Like, even though we can't take care of the whole physician problem and giving people money, that's not going to completely solve everything. Like, this is part of it. So let's add something positive. Is the link working?
Right. Well, you like the idea of that, there's somebody out there who's like, I got this really great idea and I'm really inspired. If only I had a couple $100 to buy something that could get me where I need to go with this idea. Yeah, I find that really encouraging, for sure. So if you find yourself burnout or depressed, among other things, there is a questionnaire that can help you. That link to that is in the podcast notes for the Sharp Index and the donation and scholarship.
At the end of it, I just always want to say, like,
yes,
we don't, a new survey isn't going to, like, blow our minds.
No, you're not. Yeah, this is not going to be the Rosetta Stone of depression.
Yeah.
But you could take the survey, you can donate to the scholarship, or you can apply for the scholarship and look into it, and the link on our podcast notes. So the last question I like to ask people often is, what do you think is next for you, and what do you think is next for the space? And the 3 increments I give are this year, the next 2 years, and the next 5 years.
Oh, I like that. You're life planning with everyone.
Oh, yeah, it's a job interview question, folks.
This is a job interview question. I think in the space in the next 5 years, we'll see more funding for research for organizational improvement. And I would love to be part of that. In the next 2 years, I think we'll see giant gains in scholarships and student loan forgiveness. And I think we'll see health IT companies, like the EHR companies that everyone says are terrible. I think they'll actually add positively and start working on the issue.
When they should, obviously. Yeah. I mean,
I'm moving backwards. Do you like that? In the next 1 year, we plan to increase the number of people on our board, and probably have an executive director that does most of the stuff. I really want to, we have some physicians, but I'd like it to be bigger. And so I've always tried to maintain balance with the nonprofit. So I'd love to have more people on board so it can become bigger and we can learn more.
Well, if you're listening and you feel so motivated to get in touch and see what you can do, Janae's email or an email to the Sharp Index, as well as Twitter and all of the information for Sharp Index, including, like I said, the questionnaire, donation portals, and application for the.
And I hope everybody applies. Like, I want to.
It's money. It's free money for your idea.
Yeah, it's free money, guys. Come on.
Yeah.
Like, and I just remember too, like when John was in school, he got a grant for research. This is when he was doing his MPH, and it made a huge difference in our lives, you know?
Yeah, for sure. Especially if you're a resident and like it's essentially because you work 87 hours a week, it's, it's minimum wage. For your hours, this could be, a really big deal. Maybe all you need is to go talk to somebody, or you want to go to a conference to learn something. I know there's writers' conferences for medical physicians. You can buy podcast equipment with this scholarship, no problem. Things like that. This is not obviously loan stuff and finance stuff as well.
Yeah. Yeah. And if people want to donate to that, like, we'd love to include you and give recognition for people who want to give back too.
Right. So Janae Sharp,
big or small, we're happy.
Yep. Anything counts, right? I mean, penny saved is a penny earned for sure.
Yeah.
So I want to thank you for coming, and I want to say that if anybody has stories of how this suicide of a healthcare professional impacted them, you can email me. We'd love to have you on the show. You can call in. It's something we're going to be doing on and off throughout the month of September. I know Suicide Awareness Week is just 1 week, but this is a podcast. We have weekly episodes, so we're going to do 3 or 4 episodes with similar themes. And so if you have anything that you want to add to the story, shoot me an email at podcast@mdh.com or tweet at me. My Twitter handle is available in the show notes, and we'll make sure to tell those stories as best we can. So, Janae, thank you so much for joining me. And we touched base earlier. You are living in my neck of the woods where I grew up in Southwest Wyoming, went to Salt Lake and Ogden and Provo and all those places all the time, and you're out west, huh?
Yeah. I'm in Utah. It's awesome.
I see.
The mountains are here. You guys should all come. Everyone can come.
Yes, definitely go. I miss it for sure. Not that I don't love traffic in Philly, but I definitely miss the mountains.
Traffic in Philly is terrible.
If it's not the drivers, it's the potholes. Something will kill you.
John went to Drexel, and he would just go and take the train, but
oh yeah, well yeah, okay, so that now it makes sense. So he did his stuff at Hahnemann, which is closed. We talked about that too.
He got his MPH there, so he was a dragon.
Yep.
We love Drexel.